So electrical activity of the heart, ECG and BP monitoring. Cardiac output monitoring, if you want to include this, 1.5 hours is not enough lah. So we'll do another day along with this action potential and everything. And the discussion, MTF, SBA also, I will keep it for another day. So we will concentrate on the first 3 topics first. So recap, this is what we learned last time, the phases of cardiac cycle. We have systole and we also have diastole, where the systole starts with closure of the mitral valve, closure of the AV valve initially, atrioventricular valve like mitral valve or tricuspid valve, and there is isovolumetric contraction. So this is the isovolumetric contraction. Mitral valve closes here. Then the atrial systole. After the atrial systole, the mitral valve close. Isovolumetric contraction. Then aortic valve open. Ventricular systole, proper ventricular systole. Then the aortic valve close. Isovolumetric relaxation. Then continue by the diastole. So your ventricular systole starts from isovolumic relaxation until the end of isovolumic relaxation. So that's the cardiac cycle. When you correlate with your ECG, your atrial systole correlate with your P wave, and QRS correlate with your isovolumetric contraction, and follow until your ejection, which is this is the ST segment is the time where your ventricle is actively pumping out the blood, and followed by T wave, there is a ventricular repolarization. So now we come to cardiac electrical activity. So electrical conduction system of the heart controls the contractility of the heart. So this is a automaticity. It means it occurs by itself. There is a regular rhythm to it in a normal heart. The components of the electrical conduction system of the heart consists of your SA node, which is situated in your right atrium near the entrance of superior vena cava. All these words that I'm mentioning is important for MCQ. The SA node situated in the right atrium, near the entrance of superior vena cava. This exact stem can come as a MCQ. It is situated in right atrium, so near the entrance of vena cava. Then we have AV node, which situated in the interarterial septum. Interarterial septum, not interventricular septum. Between the two arteries, interatrial septum, between the two atria, near the AV valve. This is a tricuspid valve. This is a mitral valve. It's situated at the interatrial septums between the AV valve. Then you have bundle of His, which goes in between the interventricular septum. This is both of your ventricle. It goes through the interventricular septum, which divide into right bundle branch and left bundle branch. Okay, this is right, this is left bundle branch, which anteriorly considered as a left anterior fascicle, posteriorly as a left posterior fascicle, where these are Purkinje fibers. Once it runs in the interventricular septum, it goes and gives out Purkinje fibers. These are the Purkinje fibers. On the anterior wall, it's called as a left anterior fascicle. On the posterior wall, it's called as a posterior fascicle. The depolarization starts at the SA node. It means the SA node will fire first. Then the impulse will travel through the Bachmann bundle, is this bundle. There is a bundle continues between two atrium. Okay. Then travels to the Bachmann bundle. At the same time, it goes to AV node. So the SA node fire, the impulse goes through Bachmann bundle to other side of the heart, opposite side of the heart from right to left side, and also to the same side of the heart. So where it reaches the AV node. The Bachmann bundle is not the main component. Usually SA node, AV node, bundle of His and Purkinje fibers. But Bachmann bundle is another internodal tract. We call it internodal tract, where it also is transmitting impulse to the left atrium directly. So to make sure the left atrium contracts simultaneously with the left atrium contracts simultaneously with the right atrium. So the Bachmann bundle is an interconnecting tract between the atria. This is another MCQ stems. Okay. So after the SA node depolarization, it goes to the AV node. There is a delay in the AV node to make sure the impulse has been reached to complete the atrial systole. Then the impulse transfers through the Purkinje fibers in left and right bundle branch, where anterior and posterior fascicle. Then lastly into Purkinje fibers, where it goes through the myocardium. Please note that the Beckman bundle is an interatrial conduction pathway. Remember, it's an interatrial, not interventricular. It's an interatrial, which means it conducts the depolarization from the SA node to the left atria. All these words can come as a MCQ. So this is repetition. So the cardiac conduction system transmits the signal generated by the SAN in the atria, cause the heart muscle to contract. Pacemaker signals travel through the right atrium to AV node, bundle of E's, bundle branches right and left, and to Purkinje fibers in the wall of the ventricle. Purkinje fibers transmit the signals and contract the ventricle. Again, the Purkinje fibers goes through the myocardium of both the ventricle and make it contract. Conduction system is a specialized heart muscles. All these components are specialized heart muscles situated within the myocardium. SAN situated within the myocardium of the atria, AV node within the interatrial septums, and Purkinje fiber bundle of E's all of the myocardium of the ventricle. Any dysfunction in the conduction system leads to arrhythmia. The components, once again, SA node, natural pacemaker. It's called as a natural pacemaker. It maintains the heart rate. It decides the heart rate. When there is SA node problem, when the SA node has a issue, a dysfunction, then the AV node takes over. It's situated in the RA near the entrance of SVC. AV node is an atrioventricular node in the interatrial septum near the atrioventricular valve, which is tricuspid and mitral valve. AV bundles, bundles of E's, right and left heart, and Purkinje fibers. The bundle of E's as the anterior and posterior fascicle. So once again, the full chronology, the sequence of electrical conduction of the heart. Follow the numbers and follow the components. First, we are looking at the sinoatrial node. Follow my arrow. The sinoatrial node is situated in the right atrium. You see the superior vena cava is labeled there. That's the opening. So sinoatrial node, it's a pacemaker, like a natural pacemaker of that, generates the impulse. So that impulse has a pause of 0.1 second at the AV node. It travels to the AV node and it has a pause here, 0.05 to 0.1 second. The reason for the pause, we'll talk about it. Then the atrioventricular node, from the AV node, the AV bundle connects the atria to the ventricle. This is the atrium, this is the ventricle. So this AV bundle, which is bundle of E's, connects the impulse from the atrium to the ventricle. The bundle branches, right and left bundle branches, conduct the impulses through the interventricular septum. This is the interventricular septum. The bundle of E's runs right and left from the interventricular septum. And then finally, the Purkinje fibers at the end depolarize the contractile cells of the both ventricle. So the conduction is from the apex to the endocardium. From the interventricular septum, it reaches the apex first, and the apex contract first, then followed by the other part of the endocardium. Okay. Once again, repetition, just to look at it here, start from here, action potential, initiate SA node, action potential conducted from the SA node to the atrial muscle. So this is your SA node, initially the atrial muscle. Interatrium from the right to left is the Beckman bundle is involved. Then action potential spread through the atria to the AV node. The colors, the part that's the brownish yellow part that is highlighted is the part where it's getting depolarized or it being contracted. So initial part, atrial contraction. So right and left atrial contraction, followed by full total atrial contraction before it reaches the AV node. So right atrium fully contract, left atrium fully contract, pumping the blood into the ventricle. Then the action potential spread through the atria to the AV node, where the conduction slows. This is another important, remember, at the AV node, the conduction slows down. So it's another MCQ question. The action potential travels through the bundle to the apex of the heart. This is another MCQ. The AV node sends the impulse via the interventricular septum to the apex of the ventricle first, not to the side, not to the lateral wall. It's to the apex first. Action potential spread upwards through the ventricular muscle. From the apex, it spreads upward via the Purkinje fibers. Eventually, the entire heart resting to, once it already went to the whole myocardium of the ventricle, it contracts, and then it comes to a resting state, where remaining there until another action potential is waiting for the next action potential. This is just repetition. I just want you to look at it here. This sequence here. Remember SA node, internodal pathway. Okay, which is Beckman bundle, and to the AV node. From AV node to AV bundle, which is the bundle of East, but right and left bundle branches, then finally Purkinje fiber. Remember this sequence. So the action potential. So in this slide, I want you to look at mainly the lower picture where it is mentioned about the millimeter per second and also the green. The red color mentioned the conduction velocity. It means from one component to another component, how far it take, how fast it can reaches the velocity. And the green color shows the time taken for each component of the heart to get activated. Okay, we go from one by one. The action potential generated by the SA node spread throughout the atria first. You see, the SA node is here. The action potential generated goes throughout the atria, right atrium and left atrium. Interatrial activation at a conduction velocity of 0.5 meter per second. Remember, atrial muscle and ventricular muscle have a conduction velocity of 0.5 to 1 meter per second. The number may vary in different textbooks, but it always between 0.5 meter to 1 meter per second. Atrial muscle and ventricular muscle conduction velocity. Atria and ventricle conduction velocity is 0.5 to 1 meter per second. Then the impulse reaches the AV node, where slows the impulse conduction considerably to 0.05 meter per second. Once it reaches the SA node, AV node, from SA node to AV node, you can see from atrial muscle, it was going at a fast rate of 0.5 millimeter per second. But AV node, it becomes slows down 0.05, 10 times slower. Okay, why? It allows for sufficient time to complete atrial depolarization, because the AV node, if it immediately sends the impulse to ventricle, the ventricle start contracting before the atrial contraction complete. We want the atrial systole to complete, so the complete ejection of the blood from the atria to the ventricle. So that's why the AV node slows down the impulse, giving time for the atrial contraction to complete before ventricular depolarization occurs to initiate the contraction. Next, bundle of east and left bundle branches conduct the impulse at very rapidly. The moment AV node already slows down to 0.05 second, you can see initially both atria takes around 0.09 to 0.1 second to both atrium to complete the activation and contraction. After that, AV node slows it. Then at the AV node, there is a delay of 0.07 second for that area to get activated. Next, the bundle of east transmit the impulse through the interventricular system at a very fast rate, up to 2 meters per second, even faster than your atrial muscle. So this is next faster. Okay, so at a very rapid velocity, it goes through the interventricular septum, left and right bundle branches, where it reaches your apex. So this interventricular septum takes around 0.1 second to get activated. The bundle branches then divide into an extensive system of Purkinje fibers that conduct the impulses at a very high velocity. So Purkinje fibers send the impulse upward towards the myocardium at 4 meters per second. Okay, throughout the ventricle. This results in rapid depolarization of ventricle myocytes throughout the both ventricles. So the green color is the time taken in seconds to activate the different regions of the heart. Okay, the green color. So to be honest, you don't have to remember the green color. The idea why I put the green color, if you add on all this green color cumulatively, you will get 0.8 second, which you remember in our last class, I mentioned each cardiac cycle almost lasts around 0.8 second. So that is the reason I kept this picture. If you add on the 0.09, 0.07, 0.16, all these things, 0.23 and everything, somehow it'll come around 0.8 to 0.9 second, which is the time duration for one complete cardiac cycle, which is atrial and ventricular systole and diastole. Okay, so that is the idea. Atrial activation is complete within about 0.09 second, which is 90 millisecond, following SA nodal firing. After a delay at the AV node, the septum becomes activated 0.17 second, 16 second. All the ventricular mass is activated by about 0.23 second. Okay, see all these things around 0.23 seconds. See 0.23, 0.09 and 0.16. Okay, this is the total. But the MCQ always asks about the conduction velocity. So the highest conduction velocity is Purkinje fibers at 4 meter per second. That is the highest conduction velocity. Followed by your bundle of ease, which is at the conduction velocity of 2 meter per second. Followed by your atrial and ventricle muscle, which is 0.5 meter per second. And finally, the slowest is at the AV node or SA node, both conduct at 0.05 meter per second. Remember these numbers for MCQ. So next, when we talk about cardiac conduction system, we need to talk about action potential. So different action potential, including the SA node and also the ventricle muscle, especially. The SA node also called as a pacemaker potential and ventricle muscle action potential. But for me to talk about this, we have to first talk about skeletal muscle action potential, the sodium influx, calcium influx, to compare with both. So this class is not enough for that. Keep this slide for the next topic. Atika, please remind me another day where we talk about skeletal muscle action potential initiation and propagation. We have to talk about the intercalated discs and everything. And then we talk about skeletal versus cardiac muscle action potential for better understanding. If you only talk about this without the skeletal muscle, then we all have difficulty understanding about that. It has to be done in a pair situation. So we'll do it for another day. So next we go to ECG. I will take a pause here, around 10 seconds. Anyone have any question regarding the cardiac conduction system, please ask me, because you just have to know the sequence at where it starts, where it slows down, how it goes, and then you have to know the velocity. For MCQ purpose, this is more than enough for conduction system. Remember what are the components and remember where it exactly situated. What is the sequence of events occurring? We will relate it to the ECG shortly. The cardiac cycle is the mechanical side of it. This is the electrical side of it. Electrical side occurs first, which is captured in the ECG, which is translated into the mechanical part where the cardiac cycle is occur. So depolarization and repolarization is the electrical part because of the SA node firing and AV node firing, which because of the electrical components occurring, this will cause the mechanical component, which is the contraction of the heart. The depiction of the electrical component, what capturing and showing us the electrical component is the ECG. ECG is the representation, image representation of the electrical conduction system of the heart. Any question? I'll take a 10-second pause before I go to ECG. Okay, good. So we move on to ECG. My slides are visible, right? Okay, good. So what we're going to talk about is what is ECG or electrocardiogram. In a layman term, it's just a surface representation of electrical activity of the heart. The electrical activity are occurring inside. On the surface level, we are trying to capture it so we can see. So there is a slight delay, around millisecond, from what's happening inside and what we are capturing, because there is skin impedance, muscle and everything. But it's a small delay, very, very small delay. So we try to relate the conduction system to ECG in this one slide, very simple. First, we talk about atrial depolarization, where the SA node fires. When the SA node fires, the impulse get transmitted to the right atrium and by the Beckman bundle to the left atrium. These are interatrial activation. Atrial depolarization occurs initiated by the SA node, causes the P wave. So P wave relates to atrial depolarization. Okay, with atrial depolarization, both atria get activated. So you see the yellow color means both atrium are being activated, mean actively contracting. With atrial depolarization complete, the impulse is delayed at the AV node. So when there is a deflection, upper positive means going upper deflection or going lower deflection. Whether the ECG showing upper deflection or lower deflection means something is happening. When there is a plateau, what we call as an isoelectric line, when means there is no mechanical activity is occurring in the heart. So when we see this is the P wave, where the atrial depolarization, atrial contraction is occurring. Then there is an isoelectric line, which is a short plateau line. It means the atrial depolarization is complete. The impulse has reached the AV node. At the AV node, as I mentioned, there is a delay. So delay is time given for the atrial depolarization to complete. So that's why you have the delay here. Next, the AV node sends the impulse via the bundle of E's to the interventricular septum. It goes through the interventricular septum, and then you have this QRS complex. Ventricular depolarization begins at apex, causing the QRS complex. The QR and S complex causing the QRS complex. At this point, atrial repolarization is occurring, but is masked by the ventricular depolarization. So the ECG only capturing the bigger impulse. The bigger impulse is this. This part, you can see the red color, the atria are going repolarization, mean they are going diastole now. Okay, so ventricle is undergoing systole. If you have watched the video that I've sent regarding the ECG and the cardiac conduction system, the last part they relate to ECG, they will show exactly what's happening. Please watch the video again if you haven't watched it. So next, we go to full ventricular depolarization. It means once the ventricle has undergone, the impulse has reached, this is the time taken. You see, when there is arrow, it means the impulse is going on. When there is no arrow, the impulse is transmitted. Now the atrium or ventricle getting activated. The arrow shows the electrical part. The color only without arrow shows the mechanical part. It means the contraction. So at here, the QRS complex is where the impulse are being transmitted, at next the whole atria being activated. So ventricular depolarization is complete. QRS is the transmission of the impulse towards the myocardium, ventricular myocardium, where you can see the QRS, the positive deflection and negative deflection. Once that impulse already fully transmitted, now the mechanical part is happening where the contraction is happening. No electrical activity at the moment. Now only mechanical activity. So that's why there is a isoelectric line here, ST segment. Next, followed by ventricular repolarization. It means ventricle undergoing to a resting state, which also begins at apex, causing T wave. This is repolarization, ventricular repolarization. When there is arrow, mean there is electrical activity going on. So there is a T wave. Finally, ventricular repolarization or complete. There is no electrical activity. The heart has come to a fully resting state. The diastole has completed as well. If you go back and look at our cardiac cycle, so that's where there is an isoelectric line. So remember this one picture, you can understand the whole cardiac cycle along with your electrical and mechanical activity, where when there is arrow, there is electrical activity going on and there will be a changes in the ECG. When there is no arrow, it means the electrical part has settled. Now mechanical part going on. That's why you get the isoelectric line. Okay, please go through it once again once I'm done. So now we go to the technical part of it, which is kind of boring and things are you have to memorize per MCQ sake. Okay, this is our ECG paper. All these values can come out in your MCQ. So the ECG paper, one small box corresponds to 0.04 second. One big box consists of 5 small box. So 5 times 0.04 is 0.20 second. Okay, so this is important for us to calculate the QRS component, the P value P component, and the ST, is it high or low, whether it's prolonged or shortened, all this QT prolongation, all this. For that, we have to memorize the value for it and whether we need to know the normal range. So one small box is 0.04 second, this small box, which is 1 millimeter. One big box consists of 5 small box, which is 5 millimeter, correspond to 0.20 second. Vertically, one large box correspond to 0.5 millivolt, means 5 small box. So one small box will be 0.1 millivolt. So 5 small box, 0.5 millivolt. So 5 small box equals to 1 large box. So you can see 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Vertically or horizontally, there are 5 small box, 5 small box on horizontally and vertically. Okay, all these values are important. Another important value you have to remember is the speed of our ECG paper. Normal speed is 25 millimeter per second. Okay, one big box is 5 millimeter, so it runs at 5 big box in 1 second. 5 times 5 is 25 millimeter. That's right. In a second, the ECG paper will run through the machine in 5 big boxes. Okay. So 25 mm, 1000 millisecond, 1 second. In 1 second, it goes through 5 big boxes. 1, 2, 3, 4, 5. Okay. Okay, next we come to leads. We have 12 leads ECG where we have 6 limb leads. These are 6 limb leads. We have RA, LA, and LL, means right atrium, left atrium, and left lower limb, right atrium, left atrium, lower limb. And then we have 1, 2, 3. These are 6 limb leads. RA, LA, LL, 1, 2, 3. Okay. And then the limb leads record the electrical activity in vertical plane. This is another MCQ. The limb leads can be bipolar and augmented unipolar. Limb leads can be divided into bipolar and augmented unipolar. Bipolar are, you have your 1, 2, 3, and then you have unipolar RA, LA, and LL. Okay, so your limb leads record your electrical activity in a vertical plane, vertical. Okay, and you have 6 precordial or chest leads, which is V1 to V6, which goes through from here. If you see V1 to V6, which part of the heart you can see, V1, V2, V3, look at the anterior, then V4, V5, V5, V6 at the lateral part. So from here you can see this is your heart. This is your heart is positioned in such a way. You can see V1, V2 over here, V3, V4 over here, V5, V6 at the lateral part of it. Okay. And the 6 precordial or chest leads record the electrical activity in a horizontal plane. 6 limb leads, 6 precordial, limb leads, 1, 2, 3, RA, LA, LL, vertical plane. 6 precordial or chest leads, they are V1 to V6, where they record the electrical activity in horizontal plane. Where we're going to place the ECG, I'm sure all of you know, we're not going to go through that. Okay. Next, we talk about, this is again horizontal plane. You can take about cortex of the heart is 0 point. Then you have your V1, V2, V3, V4, V5, and V6. This is the vector we are looking at the heart from the cortex of the heart on the 0 point. Okay. So this is your anterior. You can see V1, V2, V3 is the anterior part. Behind will be posterior. This is your lateral, V4, V5, V6. V1, V2, V3 will be anteroseptal lah. This is your septum. So all these are septum. V4 also some not septum. Mostly V5, V6 is your lateral part of the heart. So next we look at the positive and negative deflection of the heart. As the current travel towards the negative pole, the waveform deflects mostly downward. Okay, when current flows perpendicular to the lead, the waveform may be small or go in both directions. As the current travels towards the positive pole, the waveform deflects mostly upward. So when you have an upward reflection, it is positive. When you have a negative reflection, it is negative. It means downward reflection, it is a negative. Simply saying, when the impulse or current travels towards the heart, it will give a positive deflection. When it's going away from the heart, it shows a negative deflection. So when we look at it another way, how do we know it's a positive or negative? Positive deflection, the R wave will be longer or taller than the S wave. That is positive. When the S wave is more longer or taller than the R wave, that is negative. When both are at the equal, we call it equiphasic. Okay, R is longer is positive, S is longer is negative. But if you look at P wave, it's a positive deflection. It means the impulse will travel towards the heart. T wave as well also towards the heart. QRS, when we look at Q, R and S, R is impulse going towards the heart, S is impulse going away from the heart. Next, we have to know about your normal axis, left axis deviation and right axis deviation. Honestly speaking, you want to teach ECG to someone, you have to do it in physical. You have to get a few ECG to show them, and immediately we do example training and everything. Talking like this is a bit confusing. You just have to memorize it for now for MCQ purpose. I'm sure you all can do your own practice at the main. So how do we know axis? By looking at the axis between QRS between 30 and, so when we have a normal axis, the QRS axis between minus 30 to 90 plus. I don't know how to explain it in this picture by looking at it. You have to do it in a real ECG lah. But MCQ purpose, remember, normal axis QRS is between minus 30 to positive 90. Minus 30 to positive 90. This is MCQ. Minus 30 to positive 90, AVL to AVF is your normal axis. Left axis deviation, QRS axis less than minus 30. So minus 30 to minus 90 is left axis deviation. Right axis deviation is axis greater than 90 plus, positive, 90 to 120. You have your heart here. Let's say your heart is looking this way. Again, your heart is looking this way, right? Remember this heart, we place the heart here now. Okay, the heart is looking through this area, normal axis area. If it's towards this, you are going towards left side, your left hand, okay, counterclockwise. If it's going the clockwise, this is right axis deviation. Okay, so right side is clockwise, is right axis deviation more than 90 plus. If it's going in the counterclockwise, it is left axis deviation. If it's extremely at the behind, so if you look at it, this is your heart. If your axis is here, it is behind the heart. On the other side, it will cause an extreme axis deviation. It also causes northwest axis. In ECG, how are you going to say whether it's positive without we knowing this degree? We look at lead 1 and lead AVF. I just want to go back here for a while. When you look at it, this is your lead 1, which is we are looking at there, and then we have your AVF lead. Okay, so if lead 1 is positive, it means upward going, and lead AVF also upward going. Okay, oh sorry, I didn't put up a 12 lead ECG here lah. No, we don't have a 12 lead ECG. Okay, never mind. So we have a lead 1, we have a positive deflection. Your QRS is positive. Now we are talking about QRS. Sorry, this is about QRS. When in lead 1, your QRS is positive. And lead AVF also QRS is positive. It is normal axis. It's turned to be within 0 to 90 degrees around here. Okay, can be minus 30 to 90 also, no problem. But if you saw your lead 1 is positive, but your lead AVF is negative, it means you are at this area. You are in possible left axis deviation. If you have your lead 1 positive, lead 1 is positive, and your lead 2 is, lead AVF is, lead 1 negative, going to its way, and then your lead AVF is positive, you are looking at right axis deviation from here to here. And if both are negative, it is extreme axis, you are looking at here. I don't know how to keep it easy for you. You just have to remember 1 and AVF, and then you have to memorize this last amount. This is come out in MCQ. So now we come for some important information. This is my notes lah. One page note on ECG for MCQs lah. So in ECG, you have to divide it into few segments and few components. You have your P wave here from the beginning of P until the end of, from the beginning of R. From the beginning of P to the beginning of R is your PR interval. All these can come out in your MCQ. Okay. What is PR interval? Is from the beginning of P wave till the beginning of R wave. What is PR segment? There are waves, there are segment, there are interval. There is PR segment. PR segment is ending of P wave to beginning of R wave. You have to remember all this lah. Your QRS interval is from the beginning of your Q wave until your end of your S wave. Then goes to ST segment and everything. So if you look at it up here, I've given some information regarding the speed and everything. This is the axis, how I remember. Next, when we talk about P, we have atrial depolarization. This is your P wave, which is atrial depolarization, which is normal is less than 0.12 second, which is 3 box. 1 box is 0.04 second. So it should be less than 3 box. More than 3 box is considered as prolonged P or big. We call it P mitrale or P pulmonale. P mitrale means it's broadened, broad P. P pulmonale is tall P. It means the height has went up. So P mitrale at its left axis hypertrophy, P pulmonale right axis, right atrial hypertrophy. Left atrial hypertrophy, you have more than 120 millisecond. P pulmonale, right atrial hypertrophy, you get in pulmonary hypertension. So 0.12 second is the P wave duration, 3 boxes. Okay. Next, we have a PR. This is your PR interval. PR segment is not important. Remember the PR interval, also sometimes called as PQ interval, is the time taken impulse from atria to AVN to bundle of East. Okay, the time taken from the SA node already send the impulse to the atria. From the atria to reaches the bundle of East is beginning of the atrial contraction, beginning of P wave until beginning of ventricular contraction. Your ventricular contraction start with Q. So it's just before the Q. Okay. That is usually 0.12 to 0.2 second, which is 3 to 5 boxes. Usually 3 to 5 boxes. 1, 2, 3, 4, 5. 3 to 5 boxes is the 3 to 5 small boxes is the normal value. Okay. If it's prolonged, PR interval is prolonged, you means you're having bradycardia. That's how we find out whether patient have sinus brady or heart block. Heart block is known with PR interval. So where you have a short PR, let's say the PR is very short, the syndrome you can have is Wolff-Parkinson-White syndrome. When the PR interval is prolonged, more than 5 boxes, you can give a heart block. Is because the calcium channel blocker, beta blocker causing sinus bradycardia, digoxin effect, opioid, clonidine, all these can cause increase in PR interval. Remember this for MCQ. I have noted down here. Usually when I have this kind of small information here, it means because of MCQ. Next, you have a QRS complex. QRS complex depicts your ventricular depolarization. QRS complex. Okay, QRS complex depicts your ventricular depolarization, which is usually 0.06 to 0.10 second, which is usually 3 small square, 2 to 3 small square. Okay, 2.5 to 3.5 small square around that. Shouldn't be more than that. It's a very short and fast period. Okay, so normal taken is 100 millisecond. More than 110 millisecond, we take it as a conduction delay. It means the conduction, as I mentioned, we go back here for a while, the earlier one. If you talk about it, I mentioned, I see here, the time taken for this impulse to travel from the left and right bundle branches and Purkinje fibers very fast. They goes in a very rapid velocity. Okay. If they're going in a very slow pace, that will have a conduction delay, which is 110 millisecond. When you have long QRS, more than 110 millisecond, you suspect of bundle branch block. It means right and left bundle branch, there is a block. The conduction is not being gone. Patient having ventricular tachycardia or patient have TCA overdose, tricyclic antidepressant overdose. You will get long QRS complex. Next, we talk about QT. QT is duration of ventricular repolarization, ventricle coming back to your resting state. QT interval. QT is beginning of the Q wave until end of T wave. Beginning of Q until end of T wave. That is your QT interval. Normally 0.3 to 0.4 second, which is 10 boxes. 5 small box is 0.2 second. 0.4 second is 10 small box or 2 big box. Okay. So you have, that's why in QT we always calculate QTF for male and female. In female is bit higher than male. Normally in male is 450 millisecond. I can go up to 450 and female 460. Anything more than that we'll call as long QT syndrome. There is a way to calculate it, this formula, but not so important. So what is important when you have a long QT syndrome, you need to know what are the possible causes. We'll come to the few common causes of long QT syndrome. And when patient have a long QT syndrome, you cannot administer for certain drugs. The formula to use to find out the long QT syndrome is called as a Bezet formula. Just remember the name. You no need to remember anything. Okay. Normal findings in a normal ECG, Q wave, AVR, I think Q wave in E1, E2. Okay, sorry. This is just what we can see in a normal finding in ECG lah. If you find a Q wave in V1 and V2, Q wave usually very prominent in AVR only. If you find it in V1, V2, you have anterior septal MI. V1 to V6, when you look at your ECG from V1 to go to V6, your R will become taller and taller. This R will become taller and taller, and your S will become smaller and smaller as you are going from anterior to the lateral part of the heart. V1 to V6, chest slits. Your R will become larger and larger and larger. Your S will become smaller and smaller. You have a T wave. In AVR, your T wave will be negative, down looking. It will be positive looking in lead 2 and V4, V5. QRS duration is always constant in a normal ECG. Then, okay, this is the conduction velocity I have mentioned to you about. I remember as AVA-BP, our AVA-BP, which is the slowest is AVN node, okay, AVN, followed by your ventricle muscle 0.5 and atrial muscle. So AVN is the slowest. That's why AV, I put as AV, AVN, AVN. Next, your ventricle, then your atria, 0.5 meter per second. Followed your bundle of E's as 2 and Purkinje is 4. This is a famous MCQ. That's why I kept mentioning. So next, again, this you have to know your RR interval means distance between R wave, which is important for you to calculate your heart rate. PP interval is not important. You need to know your PR interval, as I mentioned, 0.12 second. Your P wave, the PR interval is 0.12 to 0.2 second. 0.12 to 0.2 second. Your P wave is 0.12 second, 3 boxes. Okay. Then you have your ST segment T interval. Please read it on your own lah. This is corrected QT duration. Man 450, female 460 to 470 lah. Maximum we can take. So we want to look at it again, your electrical sequence to the ECG. SA node firing, atrial depolarization, atrial systole, you get P wave. AV node firing and causing ventricular repolarization, you get QRS complex. Then finally at Purkinje fibers, when your ventricle become repolarization, you get your T wave. Okay. You can look at it, visualization of the depolarization of ventricle to emphasize vector nature of the electric field. When there is a QRS complex, starts from here, your Q starts here, QRS complex, you can see there is a, after your, this is number one is your atrial systole. This is from the, before it reaches your interventricular septum. Then it goes to your apex and goes through your myocardium, where it goes up all the way to your R wave. Then it reaches the side of your myocardium. It goes down on your R wave. And finally, when it reaches the end of your myocardium at the lateral most side, it reaches the Q wave. So QRS, this is your S wave at the end. The ECG tracing will go according to the transmission of impulse from the interventricular septum to apex to the lateral side of your myocardium. This is again just few repetition. You all can read this. I have mentioned here how does it goes and the values lah. These are my few notes I add on to this value and everything. So just look at it here. This is just a repetition of my notes here lah. Okay. Again, another repetition. Atrial repolarization, P wave, delay at AV node, you got your PR segment. Ventricular depolarization, QR complex. Ventricular repolarization, T wave. No electrical activity, isoelectric line. We got your ST segment here, your PR segment here, your ST segment here, and your after your T. All these isoelectric line where you don't have your any electrical activity. Next, how do we count the heart rate? Usually we count the heart rate between RR interval. Okay, easy way, you take the number of large boxes between your RR interval and then divide it, 300 divided by the large box. So 1, 2, 3, 4, 300 divided by 4 is 75. That's one way of doing it. Another way of doing it is if they are 1500 divided by the RR interval in small square. You just have to calculate the small square. Usually we'll take the easier way of this lah. Okay, 300 divided by the large box. How many between the RR interval in a normal ECG? Okay, so you can see there is 3 big boxes, 300, 100. When it become ready, it become prolonged. The RR interval is prolonged, then your heart rate comes down because 300 divided by 4, 305. This is the simple thing. You all know this lah. Okay. So this is a recap of our last topic. How do you relate your coronary circulation to your electrical system and your components of the heart? So we know when the ECG have some abnormality, what vessel is involved and what part of the heart is infarcted. The sinoatrial node receives major portion of the blood supply from the right coronary artery and 40% from left circumflex, and your atrioventricular node mostly from right coronary artery. So both the SAN and AVN, major portion come from right coronary artery. Next, we talk about right bundle branch and your left bundle branch mostly receive from your LAD, left anterior descending. They might have collateral from RCA and left circumflex. So mostly is LAD. Okay. Next, we talk about posterior fascicle and anterior fascicle, mostly receive from LAD as well. So how do we relate to ECG? As I mentioned that day, you have your aorta, you have your left coronary artery giving out for your left main stem, left anterior descending and left circumflex, and your right coronary artery. So you can see your right coronary artery here supplies, as I mentioned, supply RCA and AV node and RSA node and the right atrium side. Okay, and also supplies the inferior wall of the heart. So when you have a RCA infarct, you will have a problem in 2-3 AVF, which is inferior or posterior part of the heart. You can see 2-3 AVF, inferior wall supplied by your right coronary artery. 2-3 AVF, inferior wall, right coronary artery. Next, we talk about your LAD. LAD supplies your septum and also mostly your anterior wall. So you get V1 to V4 abnormalities. When you have a ST elevation in your V1 to V4, you have a left anterior descending, and your circumflex supplies the V5, V6 and lead 1. Go back to here, see this, relate to this. V5, V6 corresponds to your lateral part of the heart, as I mentioned. Again, this one as well. So your lead 1 here and your V5, V6, when you look at it, lateral part of the heart. So it is supplied by the left circumflex. So when you have an abnormality in V5, V6, you know N1 and AVL, all these are corresponds to the left circumflex artery region corresponding to the lateral wall MI. So this is just a recap of that day. This is just a summary of the whole thing to remember. Okay. 1 AVL, V5, V6, lateral part supplied by left circumflex. V1, V2, V3, V4, all are septal and anterior, mostly supplied by left anterior descending. 2, 3 AVF is RCA, right coronary artery. Few more information for MCQ. The ECG electrodes uses arginate chloride gel pads lah. AG lah. It's called arginate chloride gel pads. It's connected to an amplifier. Frequency range is 0.05 to 100 megahertz. Don't ask me the technical part of it. This is what comes on MCQ. Just know these things lah. It uses arginate chloride gel pads connected to amplifier. The range is around there, 0.05 to 100 hertz. These are the technical things that's usually asked in anesthesia. The importance of it is not very significant for us lah. Another common thing they ask is CMV5. There's a positioning of electrodes to detect ventricular ischemia lah. I also don't know exact honestly, but this is what one of the question famous. So you see this, just put as true. Okay. Then conduction, again, these are all repetition. Okay, this is just activation of the heart, as I mentioned. From the endocardium, it goes to epicardium. From endo to epi, from inner wall of the heart to the outer wall, and from the apex to base. From below, from the apex mean at the paling muncung area, and goes outwards towards the base of the heart. So activation of the heart starts from endocardium to epicardium through, and activation of the hearts go from apex to base of the heart is true. If they put it other way around, make sure it's wrong. And then as I mentioned about your QT prolongation, male is 450, female is 460 to 470. All these are potential causes of your QT prolongation. So remember these few things lah. So patient hypokalemia, hypocalcemia, hypothermia can have QT prolongation. TCA overdose, amiodarone, erythromycin, ciprofloxacin, all these are antiarrhythmics. Then you have these things. All these comes out in MCQ. That's why I just listed out lah. Just somehow remember the most important, the common ones, so you can know when you see in MCQ.